Hello, welcome again to our program, Digital Surgical Pathology Sign Out. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with the Digital Pathology Association and Path Presenter. As you know, I like bone cases, and today's case comes from the realm of bone pathology. And it's a topic that we've talked a little bit about before, but there's some additional insights that I thought would be worthwhile sharing with you today. The patient is a young woman, 15 years old, who's experienced some progressive pain in her ankle. And eventually this leads to some radiographs, which we'll take a look at here. As you can see from both all three of these images, there is a lesion with a little bit of lucency and a fairly sharp border here in the talus. Here we see it with a little hypodensity or hypo, not quite as well seen here on the AP view, but clearly they are present immediately beneath the joint cartilage. Following up on that, some additional MRI studies were done, which also showed this lesion to be centered here, just immediately below the articular cartilage, have a rim of sort of sclerotic bony type tissue, and then a central variegated pattern, as you can see on both all of these images here. So this image creates a very interesting challenge, a difficult location to get to, surgically to sample. Certainly looks to be a fairly low-grade lesion. It's very sharply circumscribed. Now, for many of us, we won't recognize that this is a portion of the epiphysis of the talus, but we can see that this patient is skeletally immature, and in fact, this is within the epiphyseal component of the talus bone in the ankle. So the surgeon gained access through a lateral approach and sent us a fragment of tissue that was quite calcified. We'll just show you here the touch preps, which is one of the techniques that can be used to try to evaluate such tissues that may not cut particularly well. As you can see, it didn't smear particularly well either. We can see that there are maybe a few cell clusters here. And you get an idea that they're somewhat round oval cells, pretty reasonable sized nuclei, sort of single cell pattern here in some areas and slightly clustered in other areas. So that gave us a little bit of idea of the cellular morphology from this touch prep. And we did also attempt to do a frozen section, which we'll look at here. As you can see, this is not very well sectioned tissue. It's sort of clumped up and clustered together. But as we look at a few of these fragments, I think you'll get a sense for a little bit of the architecture that we can tell from this kind of sampling. And it tends to reiterate what we were seeing on the touch prep, clustered cells, sort of rounded contours, and fairly prominent nuclei. Now, of course, with the digital slide, we can't focus up and down quite so well. We can also appreciate, however, that there appears to be some pretty coarse calcifications with some of these fragments. So this is certainly not an optimal frozen section exam. And I think it raises the question as to what is our goal with frozen section on a case like that. Here we'll look a little bit more at this section where we've got a little bit more. Here you can see a little bit of bony matrix here and a little bit more of the cellular tumor. And here we see maybe a few giant cells here and here. And then these sort of monotonous single cells scattered through the stroma, surrounding vessels, and so forth. Well, I don't want to belabor this point, but I think there are a couple of things to think about when we're dealing with a sample in frozen section mode that is not going to give us an optimal sample. So for the orthopedic surgeon who's trying to define what to do next with their lesion and to optimize the management of the tissue, the goals of frozen section in these sorts of cases are fairly limited. First of all, our first goal, of course, is to exclude any cases that might not require further treatment surgically. So lymphoma, for example, is a classic example of a non-surgical orthopedic disease. Now, it may occasionally require a rod or whatever, but that's not for the lesion itself. Secondly, is to sort of categorize the grade of the lesion to assist in surgical decision-making. That's sometimes we're able to do that. However, oftentimes the radiography has provided enough of that sort of grading information, such as in this case, where it was a very sharply defined with a little sclerotic rim that was already decided that this was a low-grade lesion. At times, surgical frozen section can assist with evaluation of margin. In long bone resections, for example, sometimes we'll scrape a little bit of marrow and freeze that to assess margins, but you're never going to get an optimal evaluation of the margin. So again, radiography, gross evaluation are going to be more useful in terms of intraoperative assessment than a frozen section per se. And then finally, we want to ensure that we have adequate sampling so that we're going to be able to establish a diagnosis. And then, of course, be able to triage additional treatment like culture, those sorts of things. So those are our goals. And those are attainable goals with frozen section evaluation. Even though we may not be able to differentiate an osteoblastoma from a chondroblastoma from a giant cell tumor on frozen section, we can differentiate lymphoma from most bone-forming lesions and so forth. So with that thought in mind, let's take a look at the permanent sections from this case, a little bit better preserved. And as you can see, we have a couple of chunks of good-sized hyaline cartilage, which of course we might expect given that we saw how this lesion was undermining and immediately abutting the joint space and undermining the articular cartilage. So not surprisingly, a fragment of articular cartilage collapsed into the cavity and was evacuated with surgical evacuation. Now here we see the calcification pattern, this rather coarse, chunky calcification and intervening cellular tumor. And the tumor cells are, as we saw even initially on the touch prep, quite low grade, rounded single cells with fairly central small nuclei. Then we can again see this very coarse pattern of calcification here. So this is the histologic pattern that one associates with chondroblastoma. And in fact, in a skeletally immature person, such as our patient today, a lesion in the epiphysis in that age group, skeletally not yet fused, is virtually always going to be a chondroblastoma. In a skeletally mature person, of course, you can have chondroblastoma, you can have giant cell tumor, you can have other lesions that can have that appearance. And those sorts of radiographic features. But in the patient whose epiphyses have not yet fused, you're very limited in terms of the numbers of things that can occur in that epiphyseal space and produce a low-grade lesion with a defined margin, such as we've seen. So based on that finding, based on the morphology here that we're seeing, which is fairly typical, with a little bit of that sort of coarse calcification, pericellular calcification, sometimes referred to as chicken wire pattern, we made the diagnosis of chondroblastoma. So I've emphasized that a skeletally immature person with an epiphyseal lesion, virtually all of those lesions are going to be chondroblastoma. Now, in older adults, we may occasionally see this lesion outside of the long bones. And in connection with this, I think the talus is sometimes not always regarded as a long bone, and certainly would be outside of the usual location for this sort of a process. But it does have epiphyses and ossifies in that pattern. And so understanding that embryology and histology of the talus can be very helpful. Many of these patients have a K36M mutation that's been identified, but because they are very low grade, low aggressivity, curettage is usually curative. So very quickly then, our final out diagnosis on this tumor in the talus is a chondroblastoma. And with that, we'll conclude the program. I thank you for joining us, and we hope that if you like this, you'll hit the like button. Please subscribe. We love to have subscribers and hope that you'll catch our future releases as they come. We wish you the very best with your diagnostic challenges and hope that these videos are helping you in some small way in that regard. So until next time, thanks so much for joining me.